Welcome back, everyone. Man, give yourselves a massive round of applause because you have officially made it to part 74 of our 100-part CPC exam series. I am absolutely pumped to have you here for this CPC exam practice masterclass. Before we even jump into things, make sure to like, share, and subscribe to Decode Healthcare with Harshal. It really helps us keep bringing you these deep dive explainers.
Okay, let's get right into it. We all know the pressure of the exam, right? You're moving from all that abstract guideline theory to the high-stress, timed execution of actual case studies. It's one thing to casually read the rules, but it's a whole different ballgame when that clock is ticking. So, are you ready to beat the absolute hardest ICD-10 CM traps they can throw at you?
Now, before we tackle any specific case, you have got to master our foundation, which is the ICD-10 CM safe workflow. The really crucial point here is the pause and confirm technique. You always start in the alphabetic index, but you literally never stop there. You absolutely must verify in the tabular list. Think of this workflow as your ultimate safety net against those tricky distractor answers.
Case Study 1, Outpatient Rule-Out Trap. Let's move straight to our first high-yield scenario.
Picture this. We've got a patient coming in for an outpatient evaluation of acute chest pain, specifically to rule out a myocardial infarction. But the EKG and cardiac enzymes, they come back totally normal. The physician ultimately documents musculoskeletal chest wall tenderness, likely strain. So ask yourself, what do you code here? Do you code that terrifying MI just because it was suspected?
The CPC exam decision rule is incredibly strict on this. In the outpatient setting, you must never code an unconfirmed diagnosis. If the documentation says rule out, suspected, or probable, there is no way you can code it as if the patient actually has that condition. So what's the real answer? Well, you report the confirmed diagnosis. In this exact case, you code the musculoskeletal chest wall pain or strain, and hey, if even that wasn't confirmed, you would simply code the symptom of chest pain. Basically, never guess on the outpatient side. Stick only to what is 100% known. Case Study 2, Diabetes Mellitus Combination Coding. That brings us to our second scenario. Here's the setup. We have a patient with type 2 diabetes who presents with diabetic nephropathy, and they're currently managed with long-term daily insulin injections. This is a massive, massive pitfall on the exam. Should you code the diabetes, then code the kidney disease, and then code the insulin totally separately? Look, whenever you see a scenario with multiple linked conditions, your alarm bells should be ringing loud and clear. Let's literally walk through the safe workflow steps to solve this one. Step 1, start right in the index for diabetes. Step 2, check those subterms for with nephropathy. And Step 3, verify if there's a mandatory secondary code for that insulin usage. You know, the exam writers just love to test if you're going to fall for double coding, but the alphabetic index expects a linked relationship. Whenever you see diabetes with the complication like nephropathy, the guidelines automatically assume a cause and effect relationship. So you absolutely must use a combination code rather than splitting them up into individual codes. So your primary code is that mandatory combination code E1122, which specifically captures type 2 diabetes with diabetic nephropathy. Then you have to add the secondary code Z79.4 to capture the long-term current use of insulin. Those two codes tell the entire story without unbundling the diagnosis.
Case Study 3, Adverse Effect versus Poisoning. All right, moving on, and this one is a really tricky scenario.
Imagine a patient experiencing digoxin toxicity and a cardiac arrhythmia. In scenario A, the patient took the prescribed digoxin exactly as directed. In scenario B, the patient accidentally took a double dose. It's crazy, but a slight change in wording completely flips your entire coding pathway. This perfectly illustrates the sequencing shift. If it's an adverse effect, the manifestation code, like the arrhythmia, has to go first, followed by the T code secondary. But if it's a poisoning, that poisoning T code must be sequenced first, with the manifestation coming in secondary.
Let's really lock in these definitions. Poisoning happens when there's a wrong drug, wrong dose, or wrong intent, just like our accidental double dose in scenario B. An adverse effect, on the other hand, is when the drug is correctly prescribed and taken perfectly, but a bad side effect still happens, like in scenario A. You've got to memorize these trigger words because the exam writers love to hide them in the fine print.
Case Study 4, Screening versus Diagnostic Colonoscopy. Finally, let's check out our last scenario today. We have an asymptomatic 50-year-old presenting for a routine screening colonoscopy. During the procedure, the surgeon discovers and removes a hyperplastic colon polyp. So, because an abnormality was found and removed, does the primary reason for the encounter suddenly become diagnostic? What do you actually think?
The answer actually lies in a very strict sequencing rule. You must contrast coding the abnormal finding as primary versus the screening code. The rule dictates that a screening encounter must always have the screening Z code listed first, regardless of what is actually found during the procedure.
So, looking at the exact alphanumeric codes proves this point perfectly. Your primary diagnosis must be Z12.11 for the screening encounter. Only then do you add the secondary diagnosis, K63.5, for the abnormal finding of the colon polyp. The Z code essentially anchors the original intent of the encounter.
Masterclass Summary Cheat Sheet. Wow, we have covered some serious ground today. Let's transition into a rapid-fire summary to really lock in these high-yield rules.
Here's your rapid-fire visual recap. Outpatient means absolutely no rule-out codes. Diabetes requires combination codes. Please don't split them. Poisoning versus adverse effect is all about flipping that sequence. And for screenings, that C code is always listed first. Feel free to grab a screenshot of this cheat sheet for your studies. If you thought today's explainer was helpful, you absolutely will not want to miss what's coming up next. In Part 75, we are tackling the massive topic of Evaluation and Management Coding Guidelines Part 1. We're going to break down EM principles, categories, and give you a comprehensive overview of medical decision-making. I really want to hear from you. Which of these 4 exam traps was your biggest weak spot? And honestly, more importantly, how are you going to change your coding workflow so you never fall for it again? Drop down and let me know in the comments below. Keep studying hard, trust the workflow, and I will see you in Part 75.